Joint mobilization. These techniques are utilized to decrease pain and increase range of motion. Let's start with the basics. What exactly are joint mobilizations? Joint mobilizations, also known as joint mobs, are a manual therapy technique utilized to manage and modulate pain, increase range of motion, and to treat joint dysfunctions that limit range of motion by specifically addressing the altered joint mechanics. Some factors that may alter joint mechanics include pain and muscle guarding, joint hypo-mobility, joint effusion, contractures or adhesions in the joint capsule and supporting ligaments, malalignment or subluxation of bony surfaces. To better understand joint mobilizations, sometimes it is helpful to better understand terminology. A mobilization is a passive joint movement that is used to increase range of motion or decrease pain. These movements are applied to joints and related soft tissues at varying speeds and amplitudes using physiologic or accessory motions. The force is light enough that a patient can stop the movement if they so desire. The patient should be relaxed during the treatment. However, if the movement becomes too much, the patient could stop the movement if they needed to. A manipulation is a passive joint movement that is used to increase joint mobility. These movements incorporate a sudden, forceful thrust that is beyond the patient's control. Manipulations are frequently used in chiropractic medicine to increase joint mobility. Physiologic movements are movements done voluntarily. These are commonly called osteokinematics and occur as a result of the movements of the bones. We can quantify the amount of movement available at the joints in the body with goniometers. A goniometer allows a clinician to measure body mechanics in degrees. Osteokinematics are the result of concentric and/or eccentric active muscle contractions. Movements can be measured, such as flexion, extension, abduction, adduction, internal rotation, external rotation, pronation, supination, inversion, and eversion. Accessory movements are movements within the joint and the surrounding tissues that are necessary for normal range of motion, but cannot be performed voluntarily. Accessory motions are generally associated with the physiological movement and are motions of the articular surfaces relative to one another. These movements are necessary for full range of physiological motion to occur, and commonly the ligament and joint capsule are involved in the motion. Arthrokinematics are also known as accessory motions. Accessory motions are very small movements that help with the quality of the movement. Accessory movements are very small and may be more difficult to measure as they are so small. Arthrokinematics can be altered by different mechanisms such as capsular tightness, ligamentous tightness, fascial tightness, muscle spasms, as well as other mechanisms. Component motions are motions that accompany active motion, but are not under voluntary control. An example of a component motion is the upward rotation of the scapula and rotation of the clavicle that occur with shoulder flexion. Joint play are motions that occur within the joint. Joint play is determined by joint capsule laxity. Joint play can be demonstrated passively, but the individual cannot perform the movement actively. Arthrokinematics are motions of the bone surfaces within the joint. There are 5 motions available: a roll, slide, spin, compression, and distraction. Muscle energy uses active contractions of deep muscles that attach near the joint and whose line of pull can cause the desired accessory motion. During muscle energy, the clinician stabilizes segments on which the distal aspect of the muscle attaches, and the command for an isometric contraction of the muscle is given, which causes the accessory movement of the joint. A thrust is a high-velocity, short-amplitude motion that a patient cannot prevent. A thrust is a type of manipulation. A thrust is performed at the end of the pathological limit of the joint to fix snap adhesions and/or stimulate joint receptors. Manipulations are beyond the scope of practice of many athletic trainers, physical therapists, and occupational therapists. So please be aware of your state practice acts so you can be prepared and are not overstepping your bounds. The two primary principles of joint mobilization that you must understand are concave and convex. Each joint pretty much has a convex area and a concave area. For example, the glenohumeral joint of the shoulder. In this example, the humeral head is the convex structure, and the glenoid fossa of the scapula is a concave structure. In this type of joint, this is an example of a convex structure that moves on a stable concave structure. In the example of a proximal interphalangeal joint of the finger, in this example, the middle phalange is the concave structure, and the proximal phalange is the convex structure. In this type of joint, this is an example of a concave structure that moves on a stable convex structure. We have just started talking about joint mobilizations, but it is clear early on that mobilization should be performed when there is joint and ligamentous tightness or hypomobile joints. So this begs the question, would you perform joint mobilizations on someone who has hypermobile joints? The pictures here demonstrate many different types of hypermobile joints. In the event that someone has a hypermobile joint, what should we do? With accessory movements, we have joints that are either hypomobile, normal, or hypermobile. In the case of hypomobile joints, the motion stops at some point referred to as the pathological limit, but this is short of the anatomical limit. The decrease in range of motion could be due to pain, spasm, or tissue resistance. In the event of a hypomobile joint, we need to implement joint mobilizations. Normal joints have full range of motion without pain. Hypermobile joints move beyond its anatomical limit because of laxity of the surrounding structures. In the case of a hypermobile joint, the clinician should implement strengthening, stability, taping, splinting, and/or bracing to help stabilize the joint. During joint mobilizations, there are 5 types of movement that will be explored further: the roll, slide, spin, compression, and distraction. 3 of these components are active during joint mobilization: the roll, the spin, and the slide. Joint motion often involves a combination of rolling, sliding, and spinning. During rolling, a series of points on one articulating surface come into contact with a series of points on another surface. An example of rolling would be a rocking chair analogy. As when the chair rocks forward and backwards, there are different parts of the rocker that come into contact with a series of points on the floor. An additional example would be a ball rolling on the ground. In the human body, an example would be the femoral condyles rolling on the tibial plateau. In the human body, the roll occurs in the direction of the movement. Rolling can occur on incongruent or unequal surfaces. In the body, rolling usually occurs in combination with sliding or spinning. Here is an illustration of rolling. A spin occurs when one bone rotates around a stationary longitudinal mechanical axis. The same point on the moving surface creates an arc of a circle as the bone spins. In the human body, an example of this occurs at the radial head within the humeroradial joint during pronation and supination of the forearm. It also occurs at the shoulder during flexion and extension activities, and at the hip during flexion and extension activities. Spin does not occur by itself during normal joint motion. Here is an illustration of spin. A glide or a slide occurs when a specific point on one surface comes into contact with a series of points on another surface. This typically occurs when the surfaces are congruent. When a passive mobilization technique is applied to produce a slide in the joint, it is referred to as a glide. It is common to combine rolling and sliding in a joint. The more congruent the surfaces are, the more sliding there is. The more incongruent the joint surface is, the more rolling there is. Here is an illustration of glide or slide. It is one thing to understand these three concepts, but it is another thing to understand what these three concepts mean in relation to human anatomy. The following images will try to put these concepts into perspective. If we take the knee joint, the tibiofemoral joint, we can see images of the glide, roll, and spin. If we start with the knee, we can see the glide and roll. And at the very end, you can see the spin that occurs with terminal knee extension, also known as the screw-home mechanism. You could see that little spin, the screw-home mechanism. If no rolling or gliding occurred at the knee, eventually the condyles of the femur would fall off of the tibial plateau during knee extension and flexion. That would not be good for walking and would make most movements extremely difficult. The other two motions that are available, other than rolling, spinning, and gliding, are compression and distraction. A compression occurs when there is a decrease in the space between two joint surfaces, which can add stability to a joint. This is the normal reaction of a joint to a muscle contraction. Distraction occurs when two joint surfaces are pulled apart. This is often used in combination with joint mobilizations to increase the stretch of a capsule. The following images are an example of hip distraction. In order to understand and apply the theory of joint mobilization, students must be able to understand the basic rules needed to apply the mobilization. The basic application of correct mobilization techniques is dependent upon the relationship of the two articulating surfaces and the associated sliding or gliding. Typically, there is one joint surface that is mobile and one is stable. The first rule is the concave-convex rule. In the concave-convex rule, the concave joint surfaces slide in the same direction as the bone movement, with the convex joint surface that is stable. In other words, if the concave surface of the joint is moving on a stationary convex surface, then the glide occurs in the same direction as the roll. Due to this rule, the mobilization should be performed in the same direction as the desired movement. An example would be when the tibia swings posteriorly in knee flexion. The tibial joint surface glides posteriorly. If we look at the knee joint, we can see a stable femur that is convex. The tibia is concave and is moving during the knee flexion movement. Therefore, if the concave surface of the joint is moving on a stationary convex surface, then the glide occurs in the same direction as the roll, and the concave-convex rule applies. This is an example of that. Another example would be the flexion of the distal phalangeal joint of the finger. If we look at the finger joint, we can see a stable proximal phalange that is convex. The distal phalange is concave and is moving during the finger flexion. Therefore, If the concave surface of the joint is moving on a stationary convex surface, then the glide will occur in the same direction as the roll, and the concave-convex rule applies. The second rule is the convex-concave rule. In the convex-concave rule, the convex joint surface slides in the opposite direction as the bone movement with the concave joint surface that is stable. In other words, if the convex surface of the joint is moving on a stationary concave surface, then the glide will occur in the opposite direction as the roll. Due to this rule, the mobilization should be performed in the opposite direction as the desired movement. An anatomical example of this rule is when the humerus, which is convex, swings up into abduction. The head of the humerus glides downward. The next pictures are examples of the humerus gliding downward as the shoulder is abducted. If the shoulder did not glide, the humerus would run into the acromion process. The next pictures are examples of a shoulder that rolls but does not glide. Another example would be plantar flexion of the ankle. If we look at the ankle joint, we can see the stable tibia that is concave. The talus is convex and is moving during the plantar flexion movement of the foot. Therefore, if the concave surface of the joint is moving on a stationary convex surface, then the glide will occur in the opposite direction as the roll, and the convex-concave rule applies here. This is a visual example of the two rules being applied to the knee joint. Figure A is an example of the convex surface, which is the femur moving on a stable concave joint, which would be the tibia. This is an example of the convex-concave rule, and therefore the mobilization would occur in the opposite direction as the movement. Image B is an example of the concave surface, which is the tibia, moving on a stable convex joint, which would be the femur. This is an example of the concave-convex rule, and therefore the mobilization would occur in the same direction as the movement. There are multiple positive effects that are associated with the use of joint mobilizations. These effects include neurophysiological, nutritional, and mechanical effects. The neurophysiological effects result in a stimulation of the mechanoreceptors to decrease pain. Joint mobilizations also affect muscle spasms and muscle guarding through the stimulation of nociceptors. In addition, there is an increase in the awareness of position and motion because of afferent nerve impulses. The nutritional effects are as a result of the distraction or small gliding movements which cause synovial fluid movement. The movement of the synovial fluid can improve nutrient exchange due to joint swelling and immobilization. The mechanical effects include improving the mobility of the hypomobile joints. These hypomobile joints are from adhesions and thickened connective tissue from a mobilization. The goal of joint mobilization is to loosen these tissues. Joint mobilization can also maintain extensibility and tensile strength of articular tissues. Occasionally, when performing joint mobilizations, cracking noises may sometimes occur. This does not mean that a manipulation has occurred. However, this cracking could occur as a result of placing the body in an optimal position for stretching and alignment to occur. Unless there is pain associated with the cracking, this should not be something to worry about. In fact, it's actually a desired response. Joint mobilizations need to be performed with caution. They should not be used haphazardly. The contraindications for joint mobilization include inflammatory arthritis, malignancy, tuberculosis, osteoporosis, ligamentous rupture, herniated discs with nerve compression, bone disease, neurological involvement, bone fracture, congenital bone deformities, vascular disorders, and joint effusion. If individuals have joint effusion, we may be able to use grade 1 or grade 2 mobilizations to help relieve pain, but grade 3, 4, or even 5 should not be utilized. The precautions associated with joint mobilizations include osteoarthritis, pregnancy, the flu, total joint replacement, severe scoliosis, poor general health, and a patient's inability to relax. The grading scale that is used to determine the type of mobilization is referred to as the Maitland Joint Mobilization Scale. The grading is based upon the amplitude of movement and where within the available range of motion the force is applied. A grade 1 mobilization occurs when small amplitude rhythmic oscillating movements are performed at the beginning of the range of motion. Grade 1 mobilizations are performed to manage pain and spasm. A grade 2 mobilization occurs when large amplitude rhythmic oscillating movements are performed within mid-ranges of the movement. Grade 2 mobilizations are performed to manage pain and spasm. Grade 1 and 2 mobilizations are often used before and after treatment with grades 3 and 4 mobilization. As has been previously stated, grades 1 and 2 mobilizations are primarily used for pain management and spasm reduction. Pain must be treated prior to any joint stiffness or decrease in range of motion. Any painful condition can be treated daily. The small amplitude oscillations stimulate the mechanoreceptors, which help to limit pain perception. A grade 3 mobilization occurs when large amplitude rhythmic oscillating movements are performed up to the point of limitation, also known as the PL, in the range of the movement. Grade 3 mobilizations are performed to increase motion within the joint, and these mobilizations stretch the capsule and the connective tissue structures. A grade 4 mobilization occurs when small amplitude, rhythmic oscillating movements are performed at the very end of the movement. Grade 4 mobilizations are performed to increase motion within the joint, and these mobilizations stretch the capsule and the connective tissue structures. These mobilizations are utilized when resistance limits movement in the absence of pain. Grades 3 and 4 mobilizations are primarily used to increase motion. Stiff or hypomobile joints should be treated 3 to 4 times per week, and treatment should alternate with active motion exercises. A grade 5 mobilization is also known as a thrust technique and is considered a manipulation. A grade 5 mobilization occurs when there is a small amplitude, quick thrust at the end of the range of the movement. This mobilization is often accompanied by a popping sound, also known as a manipulation. There is a lot of force and velocity that occur with manipulation. Grade 5 mobilizations require training to perform and may be beyond a clinician's scope of practice. This is a graphical representation of the 5 grades of joint mobilization. Grade 1 and 2 are for pain and spasm. Grade 3 and 4 are to increase motion and decrease adhesions. Grade 1 through 4 mobilizations occur between the beginning point in the range of motion and the point of limitation. A grade 5 mobilization pushes the joint beyond the point of limitation, up to the anatomical limit. If we go beyond the anatomical limit, we will dislocate the joint, which is no one's goal in treatment. When applying joint mobilizations, here are some general rules of thumb. All joint mobilizations follow the convex-concave or concave-convex rules. Patients should be relaxed during treatments. Explain the purpose of the treatment and the sensation that a patient should expect prior to the treatment. Evaluate the individual before and after treatment. Stop the treatment if it is too painful for the patient. As the clinician, use proper body mechanics so you don't hurt yourself during the treatment. Use gravity to assist the mobilization technique if possible. And begin and end treatments with grade 1 or 2 oscillations. The patient and the extremity should be positioned so that the patient can be relaxed during the treatment. If the patient cannot relax, then the treatment is going to be ineffective and your patient is going to be fighting you. Initial immobilization should be performed in a loose packed position. Some patients may not have enough range of motion to get into the loose pack position. In that case, the position to use is the one in which the joint is the least painful. As the clinician, you will need to firmly and comfortably stabilize one joint segment, usually the proximal bone. You can use a hand, a belt, or even an assistant to stabilize one of the joint surfaces. This prevents unwanted stress and makes the stretch force more specific and effective during treatment. The treatment force is applied as close to the opposing joint surface as possible. The larger the contact surface is, the more comfortable the procedure will be. Try to use the flat surface of your hand instead of individual fingers. That will make the treatment a lot more comfortable for our patient. The direction of the movement during the treatment is either parallel or perpendicular to the treatment plane. In this case, the treatment plane lies on the concave articulating surface, perpendicular to a line from the center of the convex articulating surface. Joint glides and mobilizations will occur as a glide and will occur parallel to the joint surface. Joint traction techniques are applied perpendicular to the treatment plane. Gliding techniques are applied parallel to the treatment plane. You will need to glide in the direction in which the slide would normally occur for the desired motion. The direction of the sliding is easily determined by using the Convex-concave or Concave-convex rule. The entire bone is moved so that there is gliding of one joint surface on the other. If gliding in the restricted direction is too painful, begin gliding mobilizations in the painless direction, then progress to gliding in restricted directions when it's not as painful. During traction, the entire bone is moved so that the joint surfaces are separated. Joint mobilization sessions usually involve 3 to 6 sets of oscillations. We need to perform 2 to 3 oscillations per second, and this treatment should last 20 to 60 seconds for tightness, or last 1 to 2 minutes for pain, with 2 to 3 oscillations per second. We need to apply smooth, rhythmic, regular oscillations. We can vary the speed of oscillations for different effects. For painful joints, apply intermittent distraction for 7 to 10 seconds, with a few seconds of rest in between for several cycles. For restricted joints, apply a minimum of a 6-second stretch force, followed by partial release, then repeat with slow, intermittent stretches at 3 to 4 second intervals. Reevaluate the joint response the next day or have the patient report at the next visit. If the patient has increased pain, we can reduce the amplitude of oscillations. If the joint is the same or better, we can perform either of the following. We can repeat the same maneuver if the goal is to maintain joint play, or we can progress to sustained grade 3 traction or glides if the goal is to increase joint play. Please realize that the patient may complain of soreness following joint mobilizations. You should only perform joint mobilizations on alternating days to allow soreness to decrease and tissue healing to occur. After joint mobilization, patients should perform range of motion techniques. The patient's joint and range of motion should be reassessed after treatment and again before the next treatment. Pain is always our guide.